institution builder and ideas, he founded the School of Research in Botany in Ravencha College. Went on to become principal of Ravencha College. Now it's a university. He was the first vice chancellor of Utkal University. This date is wrong. Utkal University, and today we have students from the life science department from Utkal University here. He was pro vice chancellor of BHU. This I confirmed. So there is this Malavia Hall house in BHU, and that houses many historical photographs of BHU, and there in the list of pro vice chancellor, his photo is there. I recently went and saw. He was president of Indian Science Congress. He was director of Department of Agriculture, Government of Orissa, and he helped establish the Central Rice Research Institute in Cuttack. So a lot of contributions to institutes within Odisha and outside. Among the many recognitions which he received, some of them includes Padma Bhushan, Officer of the Order of British Empire, Scholarship for Cambridge, and of course many institutions, public spaces, including the Parija Library in Utkal University, are named in his honor. Some words from his family side. This is his late son, Sri Lalatendu Parija. He was ex-Chief Secretary of Government of Orissa and also a cricket player, ex-Ranji player. And once during discussion, he said that from walking miles barefoot as a student to studying at Cambridge, he carried throughout his life an unwavering integrity and deep passion for the poor. He is known as a teacher who lifted others and a leader who served with humility. Now, why this lecture series? It's to honor a scientist who combined research, education, and nation building. Idea through this lecture series is to bring leading thinkers in life sciences to NISER and our sister institute, ISER Berhampur, to inspire the students to pursue science with rigor and purpose. And all this is supported by a corpus fund or endowment grant from PK Parija Charitable Trust. And these are some photographs when the check was being delivered to NISER to start with. As you all know, the first PK Parija lecture was given by Professor K. Vijay Raghavan, The Brain in Development, Health and Illness. That was in 2023. The second lecture was given by Professor Raghavendra Gadakkar, and that was about can we understand an insect society. The third lecture was given by Professor Shobha Tole, and this was the circuits of sensation. And today's lecture will be given by Professor Rajendra Badwe. Now let me, it is really my honor to say a few words about today's speaker. We are really privileged to have with us Professor Dr. Rajendra Achyut Badwe, Padma Shri awardee and former director of Tata Memorial Centre, Mumbai, which is India's oldest and largest comprehensive cancer care institution. Dr. Badwe has devoted over more than 3 decades to cancer care, research, and public health. Under his leadership, Tata Memorial Centre underwent a remarkable transformation, expanding its reach across the country, establishing multiple new cancer centers, and significantly enhancing access to high-quality treatment. What we feel distinguishes Dr. Badwe's work is not only scientific excellence, but a deep commitment to equity in healthcare. His research and initiatives have consistently focused on developing effective, low-cost solutions. Actually, you will hear this today because I got a glimpse in ISER Berhampur lecture about this aspect. And also making advanced cancer care accessible even in resource-constrained settings. Beyond the hospital, his contribution to public health have been equally influential. His advocacy against tobacco use has contributed to policy changes across several states, and he has been a strong voice for preventive health care, highlighting the role of lifestyle factors such as physical activity and obesity in cancer risk. Dr. Badwe's career has been shaped by rich international experience with appointments at leading institutions, some of which were in Tokyo and London, before returning to India to build and lead one of the country's most important medical institutions. In recognition of his contribution, he was awarded the Padma Shri in 2013, along with other national and international honors. But perhaps most importantly, Dr. Badwe represents a model of what modern science must strive for: rigorous, relevant, and rooted in societal needs. Closer here, he was one of the main architects for the upcoming cancer hospital at Jatni, for the population-based cancer registry and early detection program at Jatni and Mayurbhanj. He helped a lot to get the medical cyclotron facility to NISER, and he has been a great supporter for medical physics program at NISER. The internship program which medical physics students now seamlessly go to TMC, all its centers, is really because of him. So with these few words, now let me request Professor Ashima Bhattacharya, the chairperson of School of Biological Sciences, to kindly please chair the proceedings and invite Professor Badwe.
Many thanks, Professor Mohanty, for the introduction and the proceedings of today's event. This event actually we all are looking for, and we all are looking for the scintillating talk that is going to be presented in front of us. So with that, I invite Professor Badwe on stage, and now the stage is yours.
Thank you, Professor Ashima. Thank you, Dr. Mohanty, and thank you, Director NISER, of course. It is indeed an honor to be delivering this PK Parija lecture. Let's go somewhere else. Okay, now it can go. Yeah, thank you. So it's indeed an honor to deliver this fourth Padma Bhushan Professor PK Parija lecture. I will try and give you some insights as to what kind of research activities have happened related to cancer, how far has it been beneficial to India in particular and the world in general. My lecture would be essentially divided into certain observations that have stimulated a thought process which would take us to a different kind of dimension. I'm not saying a better dimension. Better needs to be proven over a period of time. In some aspects, they've been proven, but a different dimension. Running what's happening for the previous 20, 30 years is simple. That it's like knowing a subject, understanding it, and opening a shop. But if we can change it to make it shade better than what we were doing earlier, a simple principle that we need to wake up every day with the thought that I'm going to be better today compared to what I was yesterday. If that drive can be maintained, I think we would do small changes, and multiple small changes may have a large butterfly effect somewhere else. So I'm going to talk on cancer metastases, and we dread the word cancer, and the process that makes it dreaded is metastasis. In absence of metastases, there are hardly any deaths that happen as far as cancer is concerned. Whichever cancer, the number that either present with metastases decides the outcome, and the number that get metastases after treatment also decide majorly what the outcome is. So I'll take you through some of those thought processes, highlighting the observations. And the first observation, if metastasis kills, then what percentage of individuals present with metastasis? And I was surprised that in great majority, whether it is in developed world or in developing world, in great majority, it's a very small percentage that presents with metastases. What does that mean? That this mechanism, this facility that God has given us or nature has given us, has a phenomenal capability of constricting or retaining cancer in its own organ. In some sites, it starts off with metastasis, but it's not a common event. The example that you see on the slide here is breast cancer. My specialty is breast cancer, so majority of my research as well as examples will be related to breast cancer. So between 1970 and 1984, when Tata Hospital had its radioisotope bone scan, liver scan, and a chest X-ray to be done, in majority the women who presented with breast cancer, and I'm looking at a 10-year duration, 10-12-year duration of patients who presented with breast cancer who had this kind of metastatic workup, which is even today's standard would be considered a state of art. The number of women who had metastases, that means the tumor has left the primary organ and has gone somewhere else, either lung, bone, liver, brain, somewhere else. That's a killer disease. That happened in 11%. I want you to focus onto the tumor size with which women presented in those years. The tumor was 7.5 centimeters. Somewhere down the line in 1989, I went to UK at Guy's Hospital in London, and I had access to the Thames Cancer Registry data. I was surprised to see that in that cancer registry, the average tumor size with which women presented with breast cancer was 3 centimeters. Imagine I'm talking about only one dimension. If you look at a 3-dimensional view, you need to multiply it 3 times, and that much difference in the volume of the cancer that the lady was harboring. And metastasis at presentation was 9%. Do you find a big difference between 9 and 11? I mean, you allow a tumor to grow from 3 centimeter to 7.5 centimeter, and the metastasis at presentation increases only by 2%. Let's keep that in mind and see how this thought process evolved. Somewhere down the line, these numbers were available even for earlier dates in 2000, in 1998, from the SEER database in United States. And what you see is the early detection which happened in United States remarkably between 1980 to now, and metastases at presentation. Do you see that? The tumor size in 1970 1970 or 1980 was somewhere close to about 5 centimeter there. And today it stands at 1.2 centimeter. But metastasis at presentation is 8-9%. What does that mean? In spite of such a huge early detection, the women coming very early, the body does not allow metastasis to set in outside the primary organ. There are some protective mechanisms. Let's get on further. I now treat. My first 6 lines are same as my previous slide. I want you to focus on the last line. If we treat the above patients, say somebody with 3 centimeter, barely 30% will come back with metastases in 5 years, 4 years. Whereas somebody with 7.5 centimeter, within the first 3 years, 65-70% will come back with metastases. How do we justify that? How do you conclude? What kind of design is this? That I allow the tumor to grow from 3 centimeter to 7.5 centimeter and the incidence of metastasis rises from 9 to 11%. That's hardly any increase. That's not a statistically significant increase in incidence of metastasis. But that metastasis is hugely different after treatment. 3 centimeter, 70% chance of cure. Whereas a 7 centimeter tumor, barely 30% chance of cure. 70% will die of that disease. So we need to relook at what were our thought process before we started the treatment plan, whether it is surgery, surgery plus radiation plus systemic therapy, whether it is chemotherapy or hormone therapy or newer targeted therapy. With all these therapies, there is an increase in survival. But on what basis did we start off with this? Imagine in 60s and 70s, the only treatment that we had was surgery. If I were to stand up, there are individuals who have no metastases, I operate and they get metastasis in 3 years. What should have been my thought process? My thought process should have been that either there are micrometastases that were there at the time of surgery, but we can't measure them. That's the hypothesis Fisher put forth. That they are not measurable, they are too small to measure, and they manifest themselves within the next 2 to 3 years. The other possibility is that me as a surgeon was disseminating, was creating these micrometastases, or removal of primary tumor bestowed autonomy as far as growth is concerned on the micrometastasis which already pre-existed. Because the previous hypothesis based on which we even work today is biological predeterminism, that there is micrometastases and local surgery does not affect behavior of that metastasis. There is a little bit of contradiction in what the data is versus what we actually think happens there. Let's look at the person who propounded that hypothesis. The first hypothesis was Fisher's hypothesis. This gentleman presented this hypothesis in 1977, and in 1982 to 86, he ran some experiments. So although he has said that surgery does not make a difference, it might prevent further metastases as the tumor grows, but by itself doesn't do anything to the metastasis. Now here is the experiment, wonderful experiment, mouse experiment, wherein he implanted tumor in mouse fat pad, allowed it to grow, and once it grew to about 1.5 centimeters or 2 centimeters, he implanted another small lesion, tumor in adjacent fat, and then called that a micrometastasis. That as the primary tumor grew, there are micrometastases. He then randomly allocated these mice to have surgery versus not to have surgery, continue observation without surgery. Those who had surgery had rapid growth of this so-called micrometastases created in experimental animal. So, although he propounded that surgery by itself did not make a difference as far as the micrometastasis is concerned, he himself showed subsequently in animal experiment that removal of primary bestowed growth potential on the secondary, and it is the secondary that killed an individual. He also added further two things: a thymidine labeling index, that's the tumor being growing with micrometastasis, then surgery happened. Post surgery, the micrometastasis that grew had a rapidly increasing thymidine labeling index, indicating that there was a proliferative potential bestowed on this tumor micrometastasis by removal of the primary tumor. He also experimented, how can I prevent this growth potential? And he tried giving chemotherapy first, wherein the thymidine labeling index reduced. That's the point of surgery. This is surgery without any intervention, a rapid rise in thymidine labeling index in micrometastases. A similar rise also happened in residual micrometastases after chemotherapy. In fact, the slope of this graph and that graph is almost the same. So chemotherapy, in fact, didn't make any difference in the outcome of micrometastatic treatment. Today we know, after multiple trials being run for us last 20 years, that neoadjuvant chemotherapy does not save lives at all. But neoadjuvant hormone, this one of the graph is tamoxifen, the other is stoppage of ovarian function. Both did not have any effect on the rising thymidine labeling index. But of late, no trials have been performed to test those. So you see how human psyche works. Now, all these are animal experiments. Is it possible to do an experiment in humans? Testing my first observation that micrometastases do not grow, metastases do not evolve if surgical removal does not happen. Now, there are, I mentioned to you, I showed you right at the beginning, a small percentage, 10% of them, 9% of them present with metastases. Those who present with metastases, surgery is not the standard of care. So if surgery is not the standard of care, here was an opportunity to run a randomized study, half the patients having surgery versus half the patient not having surgery. This is what was done with the endpoint of overall survival and how distant metastases behave if the primary tumor is removed. The same experiment that I showed you in mouse was actually run in humans. This was the first trial ever performed in Tata Memorial Hospital, and I will not get into the details of the trial schema. Suffice to say that similar patients were randomly allocated to have surgery plus radiation versus having no surgery and no radiation. 350 patients randomly allocated, no difference in survival. So surgery did not make any difference in cure rates when patients presented with metastases. Did the distant metastases change at all? And here is the graph. The green line is surgery done. Blue line is surgery not done. And this graph shows how the local control was. Local control was excellent because tumor was removed. So excellent local control. Conventionally, if we control disease locally, it translates into saving of lives. But in these patients, it did not. Why should it not? Such a huge difference in local control, why should it not improve the survival? I want you to focus on to the second graph. Remember, the green line is surgery, blue line is no surgery. It's reversed. As far as distant metastases go, those who had surgery had rapid growth of distant metastases, exactly same as what was seen in the mouse experiment. So we now have in vivo experiment saying that there is a detriment by removal of primary tumor as far as established metastases is concerned. This was published in Lancet with an editorial that accompanied it. After our trial, 4 more trials have happened. All 4 trials have been exactly the same. This is a meta-analysis of the same 3 of them. 4th one has been published just about 2 months ago. and that's the diamond that tells very clearly to the right of the unity, line of unity, that there is a detriment in distant metastases growth when surgical removal is carried out. That's the graph again. The green line, no surgery, and blue line, surgery, is in opposite direction. No surgery is worse compared to, no surgery is better compared to surgery as far as distant metastasis-free survival, very statistically significant, 37% detriment in distant disease-free progression. What is important here is that it is the act of observation that has changed the observed, that has changed the behavior of cancer. If I were to deal with primary with something, the cancer was changing the moment it was attacked, as if it was a live organism, and when attacked, it would have some kind of a reaction. How do we extrapolate that to our today's understanding, or the understanding? This trial was about 15 years old. So what is our understanding as far as treatment is concerned? Suffice to say, one good observation of that study and the previous mouse study is that the act of observation changed the observed, and surgery as an event made a difference as far as survival is concerned. We needed to revisit the hypothesis that was earlier propounded by Fisher and replace it with something which was now called a surgery dissemination or autonomy hypothesis. Now, having understood this, I take you to the second observation. The first observation was that metastasis occurred, and all this time, when does the metastasis occur was a big question which was never answered, but which got answered with this study. If surgery was making a difference, can we tweak the events at the time of surgery so that the cure rates can be improved? That was the next thought. And what's the observation? While working at Guy's Hospital, the breast outpatient was on the first floor. Every day after the outpatient got over at lunchtime, I had to walk through the gynec outpatient and go to the canteen for my lunch. On the wall of the gynec outpatient was a cartoon. That's the cartoon which essentially shows a menstrual cycle in a normal menstruating woman. This is the first day of the previous period when the bleeding has begun. Post-bleeding, there is a rise in estrogen, and then there is a sudden fall in estrogen when ovulation happens. When there is a sudden fall in estrogen, and immediately after ovulation, there is a rise in progesterone, the green line. I want you to, every day going through that, it suddenly struck me that what is it that's happening in a regular menstruating woman? That a cell comes from ovary, gets into the fallopian tube, into the uterus, waiting for the sperm to come so that it can get fertilized and produce a fetus. But there is a movement of cell from one organ to the other. What is it called? It's metastasis. Physiologically, the body allowed metastasis to happen. Now, marry concept. I want you to elaborate further. Understand for a moment, in absence of IVF, induced kind of follicular cycles, or did we ever see twins? Very, very uncommon. Twins which are identical, within twins, identical twins is not uncommon. And that comes from one ovum. If you ever see non-identical twins, that comes out of two ova. What does that mean? That once one ovum is extruded, the movement of cell is abolished. There must be a switch in a woman's body that stops movement of cells. The moment one ovum is extruded, right? Now, I want you to understand this, that if I were to perform surgery before ovulation versus performing surgery after ovulation. After ovulation, first ovulation, movement of cells should completely stop. And if I were to perform surgery, the outcome should be much better. Let's look at, this data was available in Guy's Hospital archives. And we looked at that data. After my publication in Lancet, there were at least about 20 other publications. A huge difference in cure rates. Cure rates improving by anywhere from 15 to 25% by just performing surgery during the progesterogenic phase versus the earlier phase. Now, how do I use it in a woman who is postmenopausal? If estrogen is detrimental, small size, lower levels, mid levels, high levels, all of them are detrimental, then how do I do it in postmenopausal women? In postmenopausal women, there is no progesterone. There is estrogen, a small amount. A lower concentration of estrogen is there. And the estrogen, amount of estrogen is directly proportionate to the body fat. Greater the body fat, greater the estrogen. We now have solid evidence that greater the body weight of an individual postmenopausal, poorer is the survival. So there was a direct link. Can we create a progesterogenic environment by giving a depot preparation of progesterone? Was the next study. Now, as part of this study, there was a blood sample drawn on the day of surgery in these patients, and I could estimate progesterones in them. So the circulating progesterones were directly proportionate to the survival of the woman. So enough evidence to run studies related to that. So we ran a study, 1,000 patients with breast cancer. Half of them received progesterone injection, half of them did not. This is a depot preparation once given has an effect for at least 15 days after the injection is given. So the half-life is 15 days. That's the trial schema. Randomly allocated. 500 received injection, 500 did not. 10% difference in the survival. This injection cost 60 rupees. Today, a great number of interventions come from the West. Excellent. That's a fantastically good research. Each of them would cost anywhere up to about 10 to 25 lakhs of rupees. And the difference in the outcome is never more than 5-6%. But 5-6% life saved. The cost is enormous. This was published in Journal of Clinical Oncology with an editorial that so much of benefit for so little is what was. Now, I want you to understand that, yes, all these things happened, and we were trying to understand that does the tumor actually change during surgery? If it is a growth factor being released and pre-existing micrometastasis growing, it's a different thing. But does the tumor actually change during surgery? So we ran an experiment to see whether the act of observation actually changed the observed of the primary tumor. And here is the trial schema. When I start my surgery, patient is under anesthesia. I do a core biopsy under anesthesia. That core biopsy is sent for expression profile on next generation sequencing. So that's my first biopsy. Then I start surgery. If that's the tumor, I denude 50% of the surface of the tumor of its blood supply. The rest of the 50% still has its blood supply. Then I do my second biopsy from the area that still has blood supply. But the surface from where I'm doing is opposite of where surgical removal has begun. That's my second biopsy. And then the whole tumor in my hand. Third biopsy. Each of these biopsies were sent for expression profile, mRNA expression on next generation sequencing. So we have about 80-90 triplets that were analyzed. The first sample is completely vascularized, normal environment within the host body. The tumor was, the whole environment was pretty hunky-dory. In the second, some threat, some bit of blood supply was reduced, but biopsy taken from a normal surface. And the third is a biopsy when the whole tumor is in my hand. No blood supply, no oxygenation, no nutrition, nothing at all. I want you to understand what was anticipated. If I am walking on the streets of Mumbai, there is no reason why my survival instinct should be up. But if suddenly 5 goons come in front of me, I will feel threatened. The first reaction would be fright. The next, fight. And the third, if I find that this is a losing battle, flight. I wanted to run away. I would want to run away from there. The purpose of this study was to find whether the tumor goes through the same reaction. If the host has that reaction, whether each cell has that mind of itself to have the same kind of reaction. God forbid nothing should happen, but if I am held by all these 5 goons, I will stop reacting. Why should I react? 5 people holding me there, it's futile to react. So that's the third stage of the tumor, the third biopsy that we did. I want you to look at that number. 737 genes were up and down between biopsy A and biopsy B. I want also you to understand that the time interval between the first and the second biopsy is 5 minutes. I do a first biopsy, I start denuding. The denuding of the one surface, half surface of the tumor does not take more than 5 minutes. Within 5 minutes, I have done the second biopsy. I want you to understand the sentiency of the system. That the system is capable of transmitting signals from one end of the tumor to the other end. For a 3 centimeter tumor, I'm talking about billion cells in between, and the cell at the other end conveyed to the cell at on the other surface that there is a threat. And the kind of genes which had gone up and down were great majority. I want you to read only the top line. The epithelial mesenchymal transition pathways, genes belonging to that pathways were up. The moment within 2 minutes, 3 minutes. We also did the same experiment for tongue cancer. And for tongue cancer, the time interval between first and the second biopsy is 2 minutes. Same changes. So there is something. Obviously, these kind of signals can't go in by endocrine mechanisms, paracrine mechanisms. There has to be something else that moves faster than permeating signals going across the microenvironment. There has to be something different. So there are a huge amount of pathways that went up and down. A great majority were either proliferation related or the cell-to-cell adhesion reduced remarkably. The cells were free to move. The motility pathways were very rapidly going. In general, the epithelial mesenchymal transition pathways were very strongly upregulated, indicating the cells had exactly the same reaction that a host would have in an adverse environment. And this could happen in as short a time as 2 minutes or 3 minutes. We validated that with qPCR, and again, same kind of mechanisms, saying that these were the pathways that were abnormally upregulated or downregulated. And when we used the tumor tissue wherein the woman was exposed to progesterone, a lot of these pathways were downregulated. These reactions did not happen. There was a semblance of quietude that was prevailing in the cell, in the microenvironment, that the cells did not react in spite of hypoxia. Our concern was the rapidity with which the signal went. And the only other way we could imagine was the voltage gated pathways. That these are the pathways which are they open up the moment there is hypoxia, and the downstream effect of the voltage gated pathway is exactly same as what these changes happened within the first 737 genes that went up and down. And if the sodium were to enter these pathways, it would be actually depolarization of the cell surface. And depolarization is a current. How long will the current take from one surface to go to the other surface if the distance is 3 centimeters? It will go in seconds, in microseconds. It can reach the other pathway with the depolarization wave going across the cells. How do we stop this depolarization? Obviously, one of the mechanisms, since ion channels were involved, that we wanted them to be paralyzed. And we thought of two mechanisms. One was injecting local anesthetic all around the tumor. That stabilizes the ion channels, will not allow that ingress of the cations inside, and will not produce that wave of depolarization. Or the other possibility was using cannabinoids. Cannabis is another agent that stabilizes. If local anesthetic has X effect on the stability of the ion channels, the cannabinoids will have 20X effect. Both were considered, and this happened in 2011-12. By the time we finished the local anesthetic trial, we got the approval from government for using cannabinoids 2 years ago. It has taken 13 years for us to get regulatory approvals to use THC and CBD put together. And without the approvals, we couldn't have used it at all. I would have been behind bars if I were to use cannabis. And probably I would have been blessed and happier by myself using those agents. But suffice to say that this is how we wanted to run the study, and that was the background that I explained. And we ran the second randomized study of 1,500 patients. Half of them received local anesthetic on once around the tumor in 800 patients, and another 800 patients that was not performed. And that's the number. 1,583 patients, 786 received local anesthetic, 797 did not. These are randomly allocated. We confirmed if the tumor was large by an ultrasound that under surface was also injected appropriately the local anesthetic. The routine prognostic factors were balanced in both the arms for us not to see any difference. That's the difference in disease-free, recurrence prevented by 26% and deaths prevented by 29%. And this happened in all of them, whether triple negative, ER positive, HER2 positive, whichever subtypes you want to study. In all of them, it stopped, it prevented recurrence, and it prevented death. So 26% reduction in this disease-free survival and 29% reduction in deaths in those who received peritumoral lidocaine injection. Again, low cost. Each vial of lidocaine cost 104 rupees. Each vial is used in 2 patients. So in 52 rupees, 29% reduction in deaths, irrespective of any of the subtypes of tumors that one may have. I mentioned about cannabinoids. We are now 2 years into running the next group of studies, and the purpose why cannabinoids wanted to be we wanted to utilize is not every tumor in body we will be able to use local anesthetic. Suppose if I am doing pancreatic surgery, I am doing lung surgery, it's not easily possible to inject local anesthetic all around that tumor. That's why cannabinoids. Those studies are on at the moment. But to summarize, if I were to look at what were the learnings and how could these learnings be expedited by doing something as we learn, as we do our studies in the lab. And so if act of observation changes the observed, has been an observation in physics for a very, very long time. But we never had an opportunity to sit with the physicists to discuss, maybe over a cup of coffee, which is an opportunity that you all will have. I don't have that privilege sitting in a hospital. But if that kind of activity is possible, and then if I have a chemist around who has the bibliography of the properties of the molecule that he studies in his lab, something can be picked up from there. So, a platform for crosstalk. Platform while we have a cup of coffee. Next time when you're sitting for a cup of coffee, don't sit with your colleague. Sit with somebody else who is in physics lab, somebody else who is in chemistry lab, and there are something new things that happen. Novelty will come out of that crucible where there is an interface between the disciplines. We have gone down vertically, not just in subjects, but within subjects also. I do only breast cancer. My understanding of other cancer is quite lame. And that happens because I feel there are various reasons. Outcomes improve, there is goodness for patients, all that is good. The knowledge is so much, that the knowledge is so big that I have my human frailty that I will not know everything. And if I don't know everything, then I am a weakling. So what do? I don't try to increase my reading. I don't try to increase the total understanding. I reduce my universal set. I say that I will do only this much. I will work only on single petri dish. What's happening outside that petri dish, I don't know. That kind of focus or going down vertically has made us experts in our own field, but experts in what is known. If I were to tame what is unknown, I need to see what's the horizontal spread, because nature doesn't live in isolation. It is a continuum wherein every silo is merged with the other silo, and there is a help that comes from both sides. We need to have exactly same help from across. Solutions about uncertainty is another way in which education has happened. And the education allows us to be certain. I think the only person who is comfortable with uncertainty is Jugari. You know, a gambler. Gambler is damn comfortable with uncertainty. We are not. We need all certainty. If I enter the room and press a button, I need the light to come on. And then that's it. So it's because of this certainty, but how do we deal with uncertainty? And the first verse of the 15th chapter of Gita, I don't know how many of you have read it, but the first verse goes like this. Urdhvamula adhashakam ashwatham prahuravyayam chandamsi yasya parnani yastam veda savedavid. The tree of life, the tree of uncertainty, life is uncertain, is an inverted tree. Roots, the solutions for that uncertainty, the roots of this tree are staring at us. But what's the usual learning? If you want to look for roots, start digging. So we start digging. And what do we get? Some beautiful leaves, some wonderful flowers, all interesting. We have information overload with that kind of information. But that's not the solution. Solution is simple, staring at us. It is this simple solution that will give us some good outcomes. And ovulation is one such area. When nature poses problems, it also offers solutions. We just need to have a crosstalk. I needed to have a crosstalk with an obstetrician to understand, because I have already forgotten what ovulation is by the time I went into specialty of breast cancer in Tata Memorial Centre. And having looked at all these first three learnings, we need to be little skeptic. What is being taught needs to be questioned. And that questioning can happen if you have a disease called septicemia. You know what septicemia is? Infection going all across the body. Septicemia is a similar disease. This has come out of a Czech professor who used to work in Dublin. I forget the name of this person. Peter Skrabanek. Peter Skrabanek is the name. He was a professor of English in Dublin, a voracious reader and prolific speaker, complete nihilist. Whatever is most commonly known, he would try and shoot holes into it. He says, skepticism is a disease of low infectivity and successful completion of education, according to him. I have put that as medical education for myself, or confers permanent immunity. At the end of our education, we feel we have learnt everything. Disease is conquered. I don't need to know anything more. And research is put full stop. I want you to understand that we need to know that what is being taught is a small segment of what is known. What is unknown is huge, and that to tame, we need to be little skeptic. Thank you very much. Have I exceeded my time? You can have this.
So this is a wonderful talk, and being a teacher in cancer biology, every time I was also learning. So let me first give the opportunity to the students to ask questions, and then our questions from the faculty side probably will come. And volunteers, please.
I liked when NISER put my lecture in pre-lunch session. Post-lunch session is slightly difficult.
Yeah, as a student, I'm asking. So basically, any preventive measurement can be taken for cancer patients, or something that we know. Whatever the discussion you have done, it's an excellent one. That these are the observations you are making. But before that, why it is coming, how to stop this kind of, can you please tell us something about it?
Sure.
Yeah.
So, whatever I said here is for prevention of metastasis. So, prevention of the killing machine. Prevention of the machine that produces, that has the killing mechanism, is even simpler. If you look at the numbers in India, in cities, it's about 100 individuals get cancer out of 1 lakh population every year in cities. In Bhubaneswar, this number would be 70 or 75. If I go to a rural pocket, Mayurbhanj, this number there would be 45, 40. We are not missing cases. There are cases wherein there are rural pockets wherein we do house-to-house survey annually, and the numbers are not more than 40, 45. So that's the transition. If I were to go to US, the same number would be 360 per 100,000 per year. So in fact, Bill Melinda Gates Foundation pumped about $2 million in one of our rural registry pocket in Maharashtra, where breast cancer incidence was 9 per 100,000, which is 120 per 100,000 in US. Just to understand what is it that women are doing there that they don't get breast cancer. And that number remained at between 9 and 12 for last 30 years. So even trend-wise, no great increase. And they ultimately found out that women were working damn well. They were working more than what they should, and they were all thin and wiry. It was the obesity that was responsible for such a huge difference in breast cancer, as well as number of children, the age at which the first child happens. All those are examples of urbanization. There are about 40% of the cancers, the 100 cancers that I mentioned in cities per 1 lakh population per year, 40% of those cancers are related to tobacco. And we actively go to shops and buy it. Isn't it? Obesity accounts for about 20-22% of additional cancers. And another about 10% are related to infection. So good food preservation will reduce stomach cancer. We are into some etiology related to cervical cancer, which is reducing at breakneck speed everywhere in India. We don't need to probably, at least my perception is that we don't need to worry too much about it because it is reducing at a very, very breakneck speed, and plain simple early detection of cervical cancer can have more than 95% cure rates. So why worry about preventing? It's going down on its own. So infection is the third common cause. We have accounted for something like 67 to 70% of cancers in India preventable. We are already 1/3 to 1/9 of what US is, and 70% of our cancers are preventable. If we were to implement all that, India will be the only place where the whole world should live. And I'm very proud of it.
Yeah, over here. So, like you mentioned, how having surgery during increased progesterone levels would help in reducing the onset of metastasis, but that is applicable only for females. But males also get breast cancer. So, what about that scenario?
So the moral of the story is that if you look at cancer mortality in general, women do far better than men. God has been unkind to us. And if I were to quote the professor of English in Pygmalion, he mentions in a very musical way, why can't a woman be a little bit like a man? But I would say for cancer, why can't a man be a little bit like a woman? We are working on that to understand if we can create a progesterogenic environment. See, women have estrogen and a balancing progesterogenic phase. Men have only testosterone. We are incomplete individuals. So for treatment of cancer, if we can be complete for a while, we'll work on that.
So thank you for an eye-opening talk. I have a slightly basic question that when you mentioned, say, 736 deregulation of genes happen, what do they actually mean?
That would mean that their expression is of the more than an order of magnitude difference as to what are they secreting, what are they not secreting if they are suppressed. That much of difference between the stage wherein they were fully oxygenated versus the middle sample. And that effect, obviously it will translate into some kind of secretion of proteins or something else which will change the cellular function. That kind of reaction was prevented by progesterone as well as by giving local anesthetic. So I will not be wrong if I were to say that the cell was pushed into a state of being sthita prajna, not reacting.
Hello, sir. So it's a very enlightening talk, but
Yeah.
So I have two questions
Fire away.
regarding. First one is regarding the progesteronic environment that you said, but is it going to applicable to TNBC cases as well,
All of them.
like
This
triple
was
negative?
irrespective of irrespective of what the expression of receptors was. So obviously the progesterones were acting through some non-canonical pathways.
And the second case, there are three different biopsy that you have done. So did you see any change in the cell types, like the cells that were collected, because you have done IHC and all those things? So cell types like the cells that were collected from the stromal region or from the outside and all those things, did you see any apart from the 731 genes that are
Okay.
there?
So the expression profile change was exactly the same in the tumor as well as surrounding normal tissue. We also did a core biopsy of the surrounding normal tissue where the oxygen or a little bit of reduction in the blood supply had happened. So even in normal tissue, the changes were exactly the same. No difference.
Thank you.
Yeah,
Sorry.
great talk. Okay, yeah. So I just want to know a little bit more about this cannabinoids you mentioned. There are two receptors, 1 and 2. Both have a role in immunity and obesity. In fact, one of these receptors was targeted as an anti-obesity, which was discontinued. So, what is your impression that it is only the local environment or it is a systemic environment where these two receptors are playing a role? And number one, and number two, would you recommend uh, cannabinoids as a drug, okay, for cancer reduction
Incidence?
incidence?
We have no idea about what incidence, what happens to incidence by way of cannabis. But we know for sure that cell-to-cell adhesion improves remarkably when somebody is on cannabis.
Okay.
And this was also an incidental observation. In Guy's Hospital, women who used to come for breast cancer treatment would get admitted in the morning, have surgery, and by evening go home. When they came in the morning, they were asked in the ward as to whether they have had their pap smear. And if they have not had in the previous year, that could be done. So the pathology department would be informed that here is a woman who has not had pap smear, please come and collect the pap smear. So somebody from pathology would come, a cytology department would come, take the smears. And so somebody like this was there in the ward, and I get a call from cytology department. The head of cytology tells me that, will you please check with this patient that there are no cells seen in the cytology specimen that my technician picked up. So she said, I will come myself and collect the sample. So she came herself, collected the sample, went down. 45 minutes time, came back saying that, will you please ask this lady whether she is a marijuana addict? And surprise, surprise, she was. I mean, in that country, people walk with a kind of a board that I am a marijuana addict. Because if there is an emergency, the treatment matters are very different in an addict versus non-addict. So she said, yes, I am an addict. And I am on to marijuana on a regular basis. Without that, I can't live. The moral of the story was no exfoliation of cells if the person is on cannabinoids.
Sir,
Yes.
I wanted to ask, when biopsies are done in initial stages to confirm whether the tumor is cancerous, does that biopsy disturb the tumor and cause any of the metastatic reactions that you mentioned?
No evidence for that. There isn't any evidence that it happens. No.
Thank you.
Okay. Thank you for really inviting that. So I have a very basic question. So we have different stages of metastasis, starting from EMT to finally colonization and then metastasis. So
I can't hear you. I don't understand what you're saying.
we have different stages of metastasis.
Yes.
So starting from EMT, as you mentioned, then intravasation, extravasation, then circulation, and then final colonization.
Okay.
So, like most of the patients, according to your view, most of the patients that come to clinic for diagnosis, most of the time if they come at the later stages, most of the metastatic tumor are already inside the blood. So
No, I can't agree with that. If there is a data that says that only about 9 to 11% have metastatic disease at presentation, the others don't have it. Do whatever test you want. It is not there.
Okay. So, in that case, I just wanted to ask which aspect of metastasis, like, should we focus more in the research, more because I got a new perspective on EMT. So, is it EMT or the later stages of metastasis, specifically drug treatment or any other research?
I don't understand.
So, we have different stages.
I understood up to your metastatic process that intravasation, extravasation, all those kinds of things happen. What was the last bit that you mentioned?
So, as a researcher, should it
Your mic is not working. I'm sorry.
So, as a So which aspect of metastasis should we focus more, like the EMT or the final colonization stage for like drug treatment? If we are doing any research in drug treatment, so which aspect should we focus more to get better result?
I have not fully understood, but I do understand that EMT is a property bestowed on the tumor which will allow, if there are cells going out, for them to establish themselves anywhere else. And I will tell you even the mechanism. EMT changes the phenotype of the cell. Instead of a round cell, it becomes slightly elongated cell, like a mesenchymal cell. And a mesenchymal cell will traverse through a lymphatic only if it is in its longitudinal direction. If it becomes oblique like that, it will block that lymphatic. The moment it blocks that lymphatic and there is a back pressure that evolves, the first thing that happens is the lymphatico-venous communications open up. And the next cell that comes up will have access to blood vessel directly rather than going through the lymphatics. So all the protective effect of the lymphatic system will be completely lost if the cell has changed its color from normal epithelial cells to closer to mesenchymal cells. So that much quicker distant metastasis will happen, and that's one of the reasons why if you look at a sarcoma, the incidence of lymph node metastasis is close to 0, but incidence of distant metastasis is high, because the cell, unless it is straight like this, cannot traverse through a lymphatic pathway. It will block the lymphatic pathway and the next cell will get into blood vessels.
Sir, it was a nice talk. I just wanted to ask that you have mentioned that after surgical resection, the chances of metastasis was increased to 10%. What are your observations after radiotherapy? What are the chances of metastasis? And what are the chances of metastasis after different kind of surgery?
Only radiotherapy? Only radiotherapy is
Radiotherapy
used.
and chemotherapy?
Only radiotherapy is used in a very small percentage of tumors. If at all, some of the laryngeal tumors, some of the anorectal tumors are the ones that receive only radiation. Correct me if I'm wrong. Other than that, there are very few tumors that receive only radiation. Post-operatively, adjuvant radiation is done in many, but there is no visible tumor in them. So, such changes. Cervical tumor is another tumor which receives only radiation, or a combination of radiation with sensitizing chemotherapy, radiosensitizing chemotherapy. But there are some studies. I will let me recollect. This is a radiation oncologist at NCI who did multiple biopsies during the 3-week radiation of a cervical cancer patient, and found similar changes that we found during surgery evolving during radiation. So kind of a protective response. Norman Coleman. Norman Coleman is the chap who has done that study. Thank you very much. And there are enough studies wherein we give only chemotherapy to begin with. While on chemotherapy, I give chemotherapy today, and between day 4 and day 7, there is a huge shower of circulating DNA in patients who receive chemotherapy. So obviously there is something that happens. It's essentially, if you are attacked, you will react. Yes.
Yeah, so the beautiful talk, I really like the similarity you do between an ovum moving through the reproductive tract and metastatic cancer cells.
I can't hear you. I'm so sorry. Why is
Hello?
it happening that the earlier
Check.
questions were very audible and now we are not?
Yeah. Can you hear me now?
Yes.
Yeah. Okay, perfect. No, so I was saying I really liked how you drew similarities between an ovum moving through the reproductive tract and a metastatic cancer cell. But is the mode of motility the same in these two cells? And you said that progesterone essentially prevents or stops this. So is the mode of the way in which progesterone acts on these two kinds of cells the same, or what exactly is the mechanism in this?
So progesterone does not essentially work only on the follicle. It also works on other tissues. Let me give you an example. The cytologist who came to the ward to find out the marijuana addict, I asked her that if I were to give you cytology slide of a lady who is in follicular phase versus a cytology collected in luteal phase, will you be able to tell me? And the pat came the reply. He said, I just need a low power view and I will tell you whether this is follicular or luteal. I said, how is that possible? He says, in follicular phase, a cytology will give me million cells. In luteal phase, I need to hunt for a cell. So it's not just ovum. It's the epithelial cell on the surface of the cervix that also has exactly the same effect otherwise. So it can be used in any site.
Hello, very nice talk. And yes, last night we also discussed. I discussed for my interest, like you talk about metastasis and uncertainty to solutions. Uh, I'm asking about the questions about combinatorial therapy, and one of them is the immunotherapy. And we all know that although the Nobel Prize has been already received on checkpoint inhibitors, the success rate is less than 30%. So what is your say for the future combinatorial therapy or the solutions?
Right. What I'm looking at is it possible that somewhere down the line, the surgeon is put out of business? That I don't need to operate on individuals to extirpate their organs. I hope that happens. That if the immunotherapy can identify and eliminate the rogue cells, and the normal cells would then proliferate enough to get everything back to normal, then extirpative surgery can be avoided. That's an ideal situation. I don't know whether that will happen. I hope it will happen, but I don't think it will happen for the simple reason. There was a very elegant study from Oxford looking at spontaneous abortions in the first 3 months. And 97% of those spontaneous aborters had a chromosomal alignment which was not compatible with life. So what does the body do when the whole organism cannot be created because of abnormality in chromosomes? It throws it out. It doesn't have the correction mechanism. That this is abnormal, this is coming abnormal, can I make it back to normal? If it was possible, I'm sure this machine will try it. But if 95% of the spontaneous aborters have non-viable chromosomal structure, then I have some hope that surgical removal will be required in majority of the cancer, because the chromosomal alignment is such that it is not compatible with life. And if it keeps on growing, it will kill the host, but it will kill itself in the process.
Hello, sir. It was a very nice talk. So, as a student of medical physics, my question is: in radiotherapy, we apply radiation by fractionation. So, wouldn't that cause an increase in the transmitting signal of the danger in cancer cells by many times?
Yes, it will. All the radiation oncologists are working very vigorously with hypofractionation. for at least 2 sites, for prostate and for breast. We finish radiation in 5 days these days. So hypofractionation with 5 days before the tumor has the chance to do something, it would be extra painful.
But if the size is very large of the tumor, then we cannot do that hypofractionation.
Oh yes, it will be difficult. But large tumors today are not treated only with radiation. It will
They
have
are
some kind
given
of a
RTCT chemotherapy.
Yeah. But again, whether chemotherapy or not, whichever treatment you give, we need to create an environment where tumor is in a state of bliss. It will not react. It has to be a still attack.
So,
The way Americans have done today.
what was the signal of danger? So in your presentation, so what was basically the signal of the danger in breast cancer?
I don't get it. I'm sorry.
When you showed the example that when you did the surgery in a patient, so you took two biopsies, two cells for biopsy.
Yes.
So when you, what was the transmitting signal between them that there is a danger in them?
I don't understand. Oh, danger signal being received. Maybe it is hypoxia. It is the hypoxia produced at the surface. When I start cutting, that's the time it will be there. The other possibility in radiation and in chemotherapy is cell kill. If the cell gets killed, I'm sure it will have some kind of after effect immediately in the surrounding tissue. That the surrounding cells which are not yet killed will have some kind of a reaction. Or the other possibility is that once the cell is dead, then the DNA with its chromosomes will be released in the microenvironment, and that can be one of the reasons why local recurrence happens only at the site where surgery and radiation is given. It rarely is away from them. So obviously these chromosomes and the DNA with that chromosome, not the naked DNA. Naked DNA hardly has any capability of entering a cell. But with the chromatin structure, with the histones, it has the capability of entering a cell and getting inside the nucleus. There are some elegant experiments performed wherein dead cells put in a petri dish with all live cells in it. The DNA repair mechanism immediately starts in the cells which have not been damaged. Nothing has happened. But the cell perceives, my interpretation, cell perceives that, oops, my DNA is outside. That means there is a damage in my DNA. I need to have that inside and put it in an appropriate situation. The DNA outside gets inside the cell. It gets inside the nucleus into the DNA at an appropriate place and starts producing what it carries as a signal. So that mechanism exists, whether that produces a transformation and a new cancer.
My last question is there any usefulness of SRS-SBRT hypofractionation in small tumors over fractionated radiotherapy in battle with metastasis?
If you are looking at radiotherapy as the only treatment, then it will have some kind of an effect which is important the way it is for cervical cancer, the way it is for prostate cancer. But in an adjuvant setting, there is nothing to see that you are guiding the treatment for. You are just assuming that the area where the primary tumor was and excised from there, you need to give radiation there. So the efficacy parameter of that is very different than treating a primary tumor itself.
Thank you, sir.
That was a wonderful session, and I can still see few hands for ready for asking questions. So that can be taken outside. But as the lecture has come to a conclusion, I would now like to invite Professor H.N. Bose and Director NISER and Professor Vedangodash Mohanty to come to the stage. now request Professor Ghosh to felicitate Professor Badwe with a bouquet of flowers.
Thank you.
Request Professor Ghosh to hand over the memento to Professor Badwe.
Wow.
Requesting
Thank you.
now request all the members on the dais to kindly return to the seat. Thank you, Professor Badwe, for the talk. And thank you, the audience, for being a nice audience. Now it's a pleasure to thank Professor Badwe for the wonderful talk, Krishna Parija Charitable Trust, Odisha, NISER Behrampur for hosting their part of the talk, NISER Director, Deans, Faculty, Administration, Finance, Account Section, Transport Section, Library and Auditorium colleagues, all members from other institutes and NISER for joining the event. The lecture program is over with this, and now I request all to join in the high tea outside. But before everybody leaves, there is one more announcement to make. There would be a colloquium talk from the ACPS department, so the audience should not leave now. Get the snacks pack, and then after that, come back here as the audience. It's a beautiful talk on India's unique fossil record, evolutionary story of a wandering continent from whales to giant snakes. Thank you.